Happy morning, friends. Today we'll be discussing about COVID-19. I will be as precise as possible. An outline of my presentation. I will be discussing about the introduction. We will discuss brief about the virology, the epidemiology, and we will try to understand the routes of transmission, the period of infectivity, the clinical features, and what are the risk factors for severe illness, complications, the laboratory and imaging abnormalities, when do you suspect and test the patient, because we are aware of the limited resources available, and as we cannot test all the patients who are having cough and cold, we need to be specific because our resources are limited. We will discuss the steps, how do you manage such a case of COVID-19 and how do you particularly prevent the disease transmission and break the chain. This is the coronavirus, which is the important human and animal pathogen which is long known. But what coronavirus we are talking is, now it's a novel coronavirus which is labeled as COVID-19, which has been identified in China after a cluster of pneumonia cases which are being identified. This episode, our epidemic, first started in Wuhan, China at the end of 2019, where a cluster of pneumonia cases were identified in persons who have worked or visited the wildlife market in China. However, as the outbreak progressed, the person-to-person spread became the main mode of transmission, and this has turned out to be a pandemic where globally more than 6 lakh cases were identified, and this is constantly increasing its spread. In March, WHO labeled COVID-19 as a pandemic in view of its widespread across different countries. Coming to the virology, we will discuss brief about the virology of the COVID-19. COVID-19 is a beta coronavirus. It is designated as SARS coronavirus 2, and its structure of the receptor binding region is very similar to the SARS coronavirus. And the virus has been shown to use the same ACE, angiotensin converting enzyme 2 receptor for cell entry. The RNA sequence is similar to the bat coronavirus, and so it's thought that it has been likely to be transmitted from the bats to the humans, either through consumption or because of the close proximity in the wildlife market. And the SARS coronavirus 2 has spike proteins, and these spike proteins gets attached to the ACE2 receptor, and the virus enters the cell and releases its RNA, and virus utilizes the host ribosome and it results in the RNA replication, and finally the replicated RNA will be assembled and packaged, and there will be formation of new virions, and these are released into the circulation. And now we will talk about the routes of transmission. As we are aware, the initial transmission is from the bats to humans. As the epidemic progresses, person-to-person transmission is becoming more and more important. And the infectious thing is respiratory droplets. And the respiratory droplets which contain the infectious, and the virus RNA can be even isolated from blood and stool. But the fecal-oral transmission is a rare possibility. A person infected with COVID-19, even in an asymptomatic phase, so we should underline this, even in asymptomatic phase, when he coughs, sneezes or even talks, will release the virus in the respiratory droplets. And when these respiratory droplets gets contacted with the mucous membrane of the eyes, nose, mouth, the person acquires infection. These droplets can fall on the surfaces. When these surfaces are touched, when you touch your hands on your mouth, nose or eyes, the person acquires the infection. And the droplets typically do not travel more than 6 feet and do not linger in air. So hence, social distancing definitely works, and the person-to-person transmission can be prevented. And our mantra should be break the chain so that we can prevent this coronavirus forming a community transmission. And now we should understand about the period of infectivity. The period of infectivity is very uncertain. We don't know exactly after acquiring infection from when he will start to be infectious and how long he will remain infectious. The transmission occurs even from asymptomatic individual. This is the most important factor when we are talking about the coronavirus, because even before the patient having symptoms, or even when the patient doesn't acquire a disease, he can act as a carrier and he can spread the disease within the community. And the viral shedding is directly proportional to the severity of the illness, and the median duration of infectivity is 20 days. So why social distancing is important? Because we know that by seeing at this slide, we know that even an asymptomatic individual can transmit the infection, and we don't know who is a carrier. So social distancing and staying at home can prevent and can break the chain. This is a study done in China where 1019 symptomatic patients were evaluated, and they found that most of the patients developed symptoms after a median period of 5 days and after potential exposure to infection. Only some proportion of patients developed symptoms after a period of 11 days after acquiring the infection. Now we will try to discuss the spectrum of the illness, severity of the illness. It can range from asymptomatic to mild to severe or even to critical illness, even resulting in death in a minority of patients. Always remember, only minority of patients are going to die, but the burden on healthcare is very much high. So that's why we need to break the chain, so that we will not even lose those minority of patients, and we can save our humanity as a whole. And this is a study done on 44,500 patients of confirmed infections to estimate the disease severity. This study clearly shows that 81% of patients will have a mild illness and 14% will develop severe illness, which require hospitalization and proper care, and only 5% of patients will develop critical illness, and the overall case fatality is only 2.3%. And now when we talk about the mortality, what are the factors which are influencing the mortality? The factors influencing mortality are advanced age and underlying medical comorbidities. And the case fatality rate differs by location. When we see the fatality rate between Italy and China, the mortality rate in Italy is 7.2% versus 2.3% in China. It can be explained by the fact that the population which are being affected in Italy are more than 65 years of age, whereas in China, the most common age group what they are affected is between 40 to 60 years of age. Because of the elderly age which are being affected in Italy, and that caused increased mortality in the population in Italy. And what are the risk factors for severe illness? Patients who are having underlying comorbidities like cardiovascular disorders, diabetes mellitus, hypertension, chronic lung disorders, chronic kidney disease, and cancer. And these are the set of patients who are going to have a much worse outcome when compared to patients who are not having these comorbidities. And this is a study done in Italy which clearly shows that those patients who are dying, 99% of them are having some comorbidities. Only 1% of patients who are dying without comorbidities solely because of a coronavirus infection, most probably when the patients are developing acute respiratory distress syndrome. But unlikely, most of the patients who are going to die and are having some comorbidities, and these comorbidities make them more vulnerable to develop mortality. What are the lab parameters which define worse outcome, which include lymphopenia, elevated liver enzymes, elevated lactate dehydrogenase, elevated inflammatory markers, elevated D-dimer, elevated prothrombin, elevated troponin, elevated creatine phosphokinase, and acute kidney injury. These are the lab parameters which indicate that these patients are going to have a worse outcome. Now we talk about the impact of age. We already understood that higher the age, the chances of mortality and chances of morbidity are more. So the most important predictor of mortality is age. Middle age and older are the most commonly affected. When we see a study done in 44,500 patients, clearly showed that 87% of COVID patients are between the age group of 30 to 79 years, and the older age is not equal to mortality, not exactly, because older age are having worse prognosis, but it's not that all patients who are getting coronavirus at the more than age of 65 are going to die. They are fair proportion of patients who are going to survive even at the age of 65 years. And this can be clearly shown by this study, where the mortality study done in China and Italy, which shows that 92% of the age group between 70 to 79 years are going to survive and only 8% are going to die, and 75% of patients of age group of greater than 80 years are going to survive. So this clearly shows that yes, there is a significant mortality in an elderly population, but even then significant proportion of patients are going to survive. In Italy, 88% of the patients of age 70 to 79 years has been survived, and 80% of population of age greater than 80 years survived even after developing coronavirus. Only 20% are going to die after the age of 80 years. Right? Now we are concerned about the asymptomatic infection, because there is a high proportion of asymptomatic patients. It is very difficult to find them, because only when the patient developed some symptoms, we try to investigate them, we try to confirm that the patient is suffering from COVID-19, and we try to isolate them. When we don't know that this is the patient who is suffering from COVID-19, there is no way that we can prevent this transmission from the asymptomatic carrier. So we need to identify staying at home, social distancing will work and will break the chain. And we all know the outbreak of COVID-19 in a Diamond Princess cruise ship, where all 3,600 passengers and staff were screened. Among those 3,600 passengers, we found out that 619 patients were positive for COVID-19, and this denotes the rampant spread. And then among those 619 patients who are having positive for COVID-19, only half of them are symptomatic and half of them are asymptomatic. Here comes the problem. And then there is a study which has been done to identify whether these asymptomatic patients will develop some significant findings in CT scan. So all asymptomatic patients were taken into consideration who have been confirmed to have a COVID-19 by doing a polymerase chain reaction, and they have done, for all asymptomatic individuals, they have done a CT test to see whether these patients are developing any significant pathological changes on your CT chest. And this has clearly shown that 50% of patients, or even an asymptomatic persons, will develop ground glass opacities in CT scan, and 20% showed atypical changes in CT scan chest, and 30% of CT scan is normal. So you can observe that 70% of patients of asymptomatic individuals also will have significant CT scan findings. And what are the clinical manifestations? The clinical manifestations range from pneumonia, gastrointestinal symptoms, anosmia, and rare manifestations include headache, sore throat, and rhinorrhea. And the symptoms of pneumonia are same as for any case of pneumonia, which include fever, cough, dyspnea, bilateral infiltrates on chest imaging. And this was a study done on 138 patients who suffered from COVID pneumonia, which shows that fever, fatigue, dry cough, anorexia, myalgias, dyspnea, and sputum production are the most common symptoms, and with varying prevalence in these patients. 99% of patients will have fever, and dry cough occurs in around 59% of cases. And we should be able to understand the complications which are possible, which include ARDS, arrhythmias, shock, cytokine storm, which can occur only in minority of patients. And this is a study which has been done in Wuhan among 200 hospitalized patients in an ICU, where 41% of patients develop ARDS, and the most important factors which infer the most higher chance of developing ARDS are age greater than 65 years, hypertension and diabetes, and patients are having a more incidence of ARDS than other population. Then when we go for the lab findings, the commonest finding is lymphopenia, and other possibilities include leukopenia, leukocytosis, increased lactate dehydrogenase, increased aminotransferase, and serum procalcitonin and D-dimer are elevated. And high D-dimer levels and severe lymphopenia have been associated with increased mortality. Chest CT should be done to find out the severity of disease. The most common findings are ground glass opacification with or without consolidative abnormalities. And they have done a study which has compared 219 patients with COVID-19 pneumonia with 205 patients of viral pneumonia of other causes. And the CT chest findings are compared, and the findings include peripheral distribution, ground glass opacity, vascular thickening, and reverse halo sign, which are more common in COVID-19 patients, whereas pleural effusion, air bronchogram, reticular opacities are more common in other etiologies of viral pneumonia. So now, when do you suspect and when do you test those patients? Because we cannot go on testing all patients with cough and cold, as we know that the resources are limited. The COVID-19 should be considered in patients with new onset of fever or respiratory symptoms or severe lower respiratory infection. Particularly, the likelihood of COVID-19 is increased. The patient resides or traveled to a location where community transmission is present or has a close contact with a confirmed or a suspected case of COVID-19 in the prior 14 days, or those working in healthcare center. So these are the criteria to suspect that this is the case of COVID-19 pneumonia, and we need to properly test those patients. And what do you mean by close contact? When you are with a patient, with a confirmed COVID-19 patient within 6 feet for a significant period of time without wearing personal protective equipment, or having direct contact with infectious secretions without wearing personal protective equipment. And what is the test we do? And what specimen is best to confirm the COVID-19? The nasopharyngeal swab is the best and easily procured sample and can only detect 75% of cases. To detect 99% of cases, we require a bronchoalveolar lavage. By doing a bronchoscopy, we remove the bronchoalveolar lavage and we should send for RT-PCR. But it's not possible. It's not all, and it increases the chances of the healthcare providing acquiring infection. So we are not going to do bronchoscopy. We are just taking a nasopharyngeal or a oropharyngeal swab and send it for RT-PCR. And the SARS coronavirus 2 RNA can be detected with the help of reverse transcriptase polymerase chain reaction. And a positive test for coronavirus generally confirms the diagnosis of COVID-19, and the initial testing is negative, and if your suspicion is strong, you need to repeat the test so that you will not miss any case of COVID-19 pneumonia. And there are some serological tests which denotes that whether it's a recent infection or a past infection. Now comes the management. When we talk about the management, we know that it varies from patient to patient because it depends upon the patient's symptoms. Patients with minimal symptoms can be managed at home, and the management should focus on prevention of transmission to others, monitor periodically for clinical deterioration which should prompt hospitalization. At home, they should have a separate themselves from other people and animals in the household. They should wear a mask when they are in the same room or a vehicle when they are approaching healthcare authorities. Disinfection should be done of the frequently touched surfaces should be done periodically, and patients should remain isolated for at least 2 weeks after the symptom resolution. But it's not always true, but it's safe to be isolated for at least for a period of 2 weeks. So this is about the home care. And when it comes to the hospital treatment, in-hospital treatment includes treating the patient as well as preventing transmission from that patient. So the management in hospital includes appropriate infection control measures and symptomatic care. The hospital care should focus on correcting the hypoxia if present. Hypoxia can be managed by giving nasal oxygen or a non-invasive ventilator or a ventilatory support. Hospital care also includes support to care, judicial use of glucocorticoids, avoidance of non-steroidal anti-inflammatory drugs, and investigational therapies which has not been proven but can be tried like hydroxychloroquine and other drugs. Support to care includes temperature control with paracetamol, proper nutrition, and maintaining the hydration. If at all patient is developing hypoxia, He should be managed by oxygenation, ideally by a nasal bronch. Non-invasive ventilation use is discouraged as it generates aerosol and it makes the healthcare setting more infectious, and these aerosols will contain the respiratory droplets which are infectious, which can transmit the infection. In case of persistent hypoxia, intubation and mechanical ventilator support should be given, but whenever you are intubating the patient, you should have a complete personal protective equipment starting from a mask, a N95 mask is preferred, and a head shield and goggles, and gloves, all should be utilized to prevent spread to the healthcare provider. For a refractory case of hypoxia, ECMO, extracorporeal membrane oxygenation therapy, can be initiated. Glucocorticoids are generally contraindicated but can be used in caution if the compelling indications like chronic obstructive pulmonary disorder or asthma are present, which may respond to glucocorticoids. But as studies show that NS glucocorticoids increase the risk for mortality in patients with influenza, and it also delayed the viral clearance in patients with Middle East respiratory syndrome coronavirus infection. So glucocorticoids should be used only when they are absolute or compelling indication like asthma or COPD. NSAIDs used early in the course of the disease has shown to have a negative outcome, better to avoid, and NSAIDs can be replaced by using a paracetamol for temperature as well as myalgia's relief. Remdesivir is a novel nucleotide analog which has shown activity against the SARS coronavirus 2 in vitro, and this can be tried, but there is no definitive guidelines which will support treatment with remdesivir. Hydroxychloroquine and chloroquine reported to inhibit SARS coronavirus 2 in vitro. Use of chloroquine has reportedly associated with reduced progression of disease and decreased duration of symptoms. And this is a study of 36 COVID-19 patients where usage of 200 mg of hydroxychloroquine thrice daily for 10 days was associated with higher rate of undetectable SARS coronavirus 2 RNA on the nasopharyngeal specimen at the day 6 compared with only supportive treatment. The only problem with use of chloroquine and hydroxychloroquine utilization is QT interval prolongation and retinal toxicity, which can be very worrisome, particularly in elderly population. So always check a baseline ECG, check for the QT interval before giving hydroxychloroquine or chloroquine. And even Indian Council of Medical Research has given it as a prophylaxis for all healthcare providers who are prone to be exposed to the coronavirus patients. So to take hydroxychloroquine or a chloroquine after taking due measures and after removing, considering those contraindications which should not be used. And there's a doubt regarding the optimal dosages. There are different dosages which has been tried. One of the dosages is 400 mg twice daily on the day 1, followed by 400 mg once daily for 5 days, or 400 mg twice daily on first day and followed by 200 mg twice daily for 4 days, or 600 mg twice daily on the day 1, followed by 400 mg once daily for 5 days. Next, the most important aspect is prevention, and at society level, social distancing will definitely work. Stay home will help to break the chain. Frequent hand wash should be propagated. Disinfection of the frequently touched surfaces will also help. At healthcare, screening patients for symptoms suspicious of COVID-19 like fever, cough, dyspnea, if possible even before he comes to hospital with the help of your modern video consultations can help to us to take additional precautions when they come, like making a patient wear a face mask, isolating him from other patients. All this will help to prevent the spread. Elective care of other diseases should be discouraged, particularly when there is a high rampant community spread. Personal protective equipment utilization should be based on the circumstances. N95 mask is must, particularly if aerosol generation procedures are being performed. Isolation of patients is always important, and airborne precautions should be done. And should follow travel guidelines, wash your hands, cover your mouth and face, avoid care facilities, practice social distancing, clean and disinfect, stay home when sick, and maintain healthy habits. So these are the aerosol generating processes like bag and mask ventilation, intubation, tracheostomy, CPR, non-invasive ventilation or bronchoscopy, where you should definitely use an N95 mask. it has potential to prevent the spread of the infection. So if healthcare personnel is asymptomatic and there's a dilemma, particularly what should you do when a healthcare worker who has a potential exposure? For example, we are seeing in papers that we have isolated a case and this patient has contacted a doctor 4 days back, and now we don't know whether this doctor has also acquired infection. So it again depends upon the duration of exposure, the patient's symptoms, whether the patient was wearing the mask or not, the type of personal protective equipment used by the provider, whether aerosol generating procedure was performed or not. This all factors will define whether the healthcare provider is at risk for developing infection. If a healthcare personnel is asymptomatic, he can continue to perform his routine activities provided that he uses a proper face mask, he uses all proper techniques like frequent hand wash, and once he develops symptoms, he should be definitely isolated and he to be have done a COVID-19 test. And even COVID-19 test should be done at the initial phase also, because we can detect an asymptomatic phase and we can isolate him so that he will not spread the disease. Prepare and don't panic is your idea in all this, like in preventing this disease, and we need to break the chain and we should be successful in isolating the cases, and we should be successful in treating the cases, and we should be successful in breaking the chain of coronavirus. Thank you.